No video today and no PowerPoint, so we're a bit limited in our resources, but you know, at Bite Medicine, we're always willing to crack on no matter what. So I'm so sorry, I've just finished a really long day at work, overran massively and wasn't expecting it, but not to worry, we will get through this. For those of you who don't know me, my name is Shoaib. I'm one of the co-founders of Bite Medicine, and we're absolutely delighted to be holding a webinar series with GKT MSA, and it's our pleasure. Without wasting too much time, this is a webinar on ECGs. And what I aim to cover, it's a three-part series. Today, we're going to look at the basics of ECG interpretation. So how to tackle an ECG and a bit of pathology. That will really give us the grounding of how to approach ECGs when you're in exams and when you're in OSCEs, when you're on the wards. People find ECGs really difficult. When you break them down to their bases, they are actually not hard, okay? So that's part one today, just going through the basics. In a few weeks, I think 2 weeks time, I'll be doing a webinar on ACS, so mainly STEMIs and STEMIs, and looking at more ECGs related to that. And finally, one of my colleagues, Richard, will be doing high yield ECG cases in a month. So going through this three-part webinar will give you a really good grounding with regards to ECGs and the high yield cases that can come up, really. So let's aim to crack on, smash through this, and the slides and recordings, providing there are no technical issues, which I'm hoping there won't be, will be uploaded to our website, app.bitemedicine.com. And also, for those of you who don't know, we actually have quite a comprehensive question bank and SBA question bank and textbook. All our webinars, all our questions, all our textbooks are on our website. A bunch of them are free. Some of them you have to pay for, but the good news is if you are part of GKT MSA, you get a 30% discount. I will put the code in the chat. So using this code, you can get a 30% discount to our website. So please do hop on, check it out. I won't dwell on this because we've already kind of wasted a lot of time. Okay, this is an ECG. I hope this doesn't come as a surprise to anyone. 12 leads. So my question to you is, how many electrodes go on the patient? This is a 12 lead ECG. How many electrodes go on the patient? So everyone is saying 10. So this is a bit confusing. 10 electrodes, but 12 leads. Why? It's the $1 million question. So you all know that there are 10 electrodes, and you all know that there are 12 leads. But why then do we have 12? Why do we have 12 things appearing on this ECG, but only 10 electrodes? Vectors, yes. People said triangles, vectors, exactly. So we'll get onto that. That's the most difficult concept of ECGs, understanding that the ECG is not a single recording, but it's a vector looking at movement of essentially electricity or depolarization across the heart in different planes. And that's why each one of these, can you see my mouse, by the way? I hope you can see my mouse, but each one of these has a slightly different morphology. So lead 1 looks a bit different from AVR, which looks a bit different from V1. And that's because they're all looking at the heart in a slightly different view. The next point is this normal or abnormal? That's always the first question you need to ask yourself in medicine. If it's an X-ray, if it's an ECG, if it's a blood test. So is this normal or abnormal? Okay, so we've got some normals and we've got some abnormals, but there's T-wave inversion here, yeah? So is that normal or abnormal? I'll ask the question again. I thought, isn't T-wave inversion a sign of the person's having an MI? No? Very, very good. Okay, so I thought this would cause some confusion. I always got confused by this. To be honest, I hated ECGs at med school, but T-wave inversion in lead AVR and in lead 1 is acceptable. You're allowed to have T-wave inversion in these two waves. Remember that, because I'm going to test you later. Okay, so basically that's a normal ECG for those of you who were confused. That's normal. Cardiac depolarization, how does it work? So going back to our even A-level biology, we have the sinoatrial node, and that triggers the cardiac depolarization. It's the pacemaker of the heart. Inbuilt, the heart sets its own rhythm. You send out waves of depolarization across the atria, and they eventually converge at the atrioventricular node. The atria contract, no problems there, and then there's a slight delay at the atrioventricular node. Current or depolarization then passes through the bundle of His, down the right and left bundles, through the Purkinje fibers, and through the ventricles. So that is really important, because when it comes to certain pathologies, like heart block or bundle branch block, you need to understand this basic diagram. So the point is sinoatrial node to the atrioventricular node, down the bundle of His, through the right and left bundles, and into the ventricles. So I hope that's quite straightforward so far. So what does an ECG actually measure? The ECG measures the flow of positive charge, essentially. So if you have positive charge flowing towards the electrode, you get a nice upward spike. If positive charge is flowing away from the electrode, you get a downward spike. Very important concept, because the whole of the ECG morphology revolves around this principle. Okay, so positive charge in this context is depolarization. So the flow of these depolarizing waves along these fibers, if you get flow depolarization towards an electrode, you get a positive spike. If the positive wave, i.e. the depolarizing wave, is moving away from the ECG electrode, you get a negative spike. Again, I hope all these concepts are simple so far. Any questions, just shout, because if you don't understand this stuff, then you're going to struggle later. So I hope you're with me so far. Fine, so we know how depolarization spreads through the heart. We know positive charge flowing towards an electrode causes an upward spike. But what does that mean in terms of the ECG itself? Sinoatrial node, depolarization spreads through the atria, and that gives you a P wave. So what does the P wave represent? Going back to basics, I know these are easy questions. What does the P wave represent on an ECG? Good, atrial depolarization. So we get depolarization spreading through the atria, and that gives us our P wave. It then gets to the atrioventricular node, where there is a slight delay. Okay, the atrioventricular node stops current from passing through immediately. It holds the current up. It's like a checkpoint. And that's really important, because it allows for good coordinated contraction. And that's why you have a flat line after the P wave. And what's this interval between the P and the R wave known as? It's kind of in the name, but yeah, what's the interval between the P and the R wave? The PR interval. So you need to know the timings. That's really important, and we'll come on to that. So the reason you have a flat line after the P wave is because the AV node holds the current for a bit, and then it lets the current go through into the ventricles, and you have the QRS complex. So QRS complex represents ventricular depolarization. You then have a slight pause once depolarization is done, and then you have ventricular repolarization, which is the T wave. And that's your ECG cycle, simple. People are asking about the PR interval, etc. Don't worry, that's all coming. And someone has asked an excellent question that I was just going to ask myself. Where is atrial repolarization in this? We've got ventricular and atrial depolarization. We've got ventricular repolarization as the T wave. Where is atrial repolarization? Why does it not exist in the ECG? Because the atria do repolarize. Very good. So two things. The atrial repolarization is a small current, okay? ECG, the bigger the spike, the bigger the current. So the QRS is the biggest spike on the ECG because the ventricles depolarize with a large current or a large amount of charge, if you will. Atrial repolarization involves small flows of charge, small currents. And secondly, it happens around the QRS the same time the QRS complex is kicking off. So it just gets lost in the QRS complex. So you don't see it. The QRS complex just dominates it. Okay. So if you were listening, you will hopefully be able to answer this question. If you pop over to Menti, oh, hold on, you probably can't see my Menti just yet. So if you pop over to Menti and answer this. T-wave inversion is normal in which of the following leads? Please answer on Menti and not in the chat. I will have a look at some of your questions. Okay. I'm going to get to your questions in the following slides. Interesting. So 13% of you got it right. See, this is a tricky question. I can see why there's confusion. Oh no, sorry. Can you see my PowerPoint? Can you see my PDF? Yeah, good, sorry. So the answer is V1, sorry, that's incorrect on the slides. The answer is V1. So it's normal in V1 and AVR. In lead 1, T-wave inversion is abnormal. In lead 2, it's abnormal. In V4, it's abnormal. In V1 and AVR, it's acceptable. The other leads where T-wave inversion is acceptable is in V2, lead 3, and AVF. Don't get confused between V1 and lead 1. They're two different things, looking at the heart in two different planes, as I will show you. T-wave inversion is normal in V1 and AVR. Oh God, okay, sorry. Hopefully you can see that now. So yeah, T-wave inversion is normal in V1 and AVR. It can be normal in V2, lead 3, and AVF. Don't get confused between V1 and lead 1, two separate things. Okay, moving on to the next slide. We've gone over this. We know what so simple things. We know what the QRS and T waves are now. So hopefully that all makes sense. Now we need to get into our minds the different intervals on the ECG waveform. So we have our PR interval. What would cause a prolonged PR interval? And this is the time, 120 to 200 milliseconds. You just need to learn this. So remember, this is atrial depolarization, and then you have a period where the current is held at the atrioventricular node. So what's going to extend this? Exactly, heart block. For those of you who don't know what that is, that's basically slow conduction through the atrioventricular node and into the ventricles. If the atrioventricular node is holding on to that current for too long, this PR interval will be prolonged. Okay, so heart block causes a prolongation of the PR interval. QRS complex, typically under 100 milliseconds. You need to know this, very important. ST segment. Why is the ST segment important in what disease? This is really important. Myocardial infarction. And bonus points, typical med school question. Patient comes in with chest pain, young patient comes in with chest pain. The ECG shows diffuse ST elevation. What's the diagnosis? Diffuse ST elevation in a young patient with chest pain. Pericarditis. Yes, very good. That's bonus points. And again, we're going to come on to all of these rhythms, so don't worry if you have no idea what I'm talking about. We're just doing the basics now. We'll come on to disease later. And the QT interval. In basic words, what does the QT interval represent? Okay, I'll tell you this one because it's a bit long, but it's basically the time it's take from ventricular depolarization to ventricular repolarization. Because remember, QRS means ventricular depolarization, T wave means ventricular repolarization. The QT measures the time between those two. And as we said, T wave inversion is normal in V1 and AVR. Fine. So one thing which really confused me, we now know the ECG morphology, but the QRS used to really confuse me at medical school. So I put a slide here, and it looks different in every lead. It looks different in 1 to AVR to AVL, and this gets really confusing because you don't know if that's normal or abnormal. And no one actually ever told me this until I went and kind of read up on it myself, but how you actually name the QRS complex and what looks normal and what looks abnormal. So this is a normal ECG. I've just chopped a bit off, but you can see that actually the QRS can be positive and it can be negative. That's absolutely fine. It just depends on the direction of current flow according to which lead you're using. And sometimes you might not even have a Q wave. It might just be an R and an S wave. So these are things to be aware of. And this is what this slide shows. So the Q wave is the first negative wave after the P wave. A Q wave is always negative. You can't have a positive Q wave, it just doesn't exist. An R wave is the first positive wave after a P wave, and the S wave is the first negative wave after the R wave. It's all written there. So sometimes you might just have a Q wave on its own, no R, no S wave. Sometimes you might have a small Q wave, a big R wave, and a small S wave. This is what we often see actually, this QRS complex. Sometimes, as I said, no Q wave, just an R wave and an S wave. And you have various different patterns, okay? And this is important to know because certain patterns are seen in certain diseases. And again, we're going to come to this. But again, for those who may have read up a bit about ECGs before coming to this lecture, what does this RSR dash pattern represent in V1? If we see that pattern, good. Ryan has got it. This is right bundle branch block if it's in V1. And if it's in V6, I think that's left bundle branch block. But that's why it's really important to understand these different morphologies. And you might be thinking, what does the R dash mean? So small r means that the initial R wave is small, followed by an S wave, which is this negative wave here. And R dash means there's a second R wave, which is this big spike here. And it's in capitals because it's the biggest wave, okay? So small r for this small R wave, small s for this small S wave, and big R dash for this second big R wave. So all I want to say here, you don't need to know this inside out, but just realize there are different patterns of a QRS complex. Okay, so I want you to calculate the heart rate in the ECG shown. This is, you need to know this for med school, definitely. So have a look at it. And then I'll head over to Menti and you can put your answers in. Please don't put it in the chat. I'll give you like 20 seconds and then we can pop over to Menti. Someone's asked, what's a bundle branch block? Very good question. We're going to come to that in the pathology section in the next webinar. Today is just covering basics. So I hope you've all had a chance to calculate the rate. Can you guys see Menti now? Has it switched over? Yes, it has. Okay, nice. That's the ECG. Really important that you know how to calculate heart rate. You'll be asked it for sure in your OSCEs and on the wards. And if you don't know how to calculate the heart rate on an ECG, it usually does tell you at the top, but sometimes consultants like to quiz you. And if you don't know how to calculate it, you'll look a bit foolish because it's quite a straightforward thing. Very good. 80, nailed it. So how do we calculate heart rate? It's 300 divided by the number of squares between each RR interval. So annoyingly, I don't have a pointer here, but if you look, this is the R wave here. Remember, it's the first positive deflection after the P wave. This is another R wave here. If we count the number of boxes between, it's roughly 3.5. Okay, or 3.6 if you're really being precise. And if you do the maths, 300 divided by 3.6 is roughly 80 beats per minute. Going back to even further basics, if you can't remember that formula, each little box on the ECG represents 0.04 seconds. A big box contains 5 small boxes. So a big box or a large square is the equivalent of 0.2 seconds. So one small box is 0.04 seconds. One big box is 0.2 seconds. So if you know that, okay, I have one heartbeat occurring in 3.5 boxes, 3.5 boxes is equivalent to this amount of time, you can then work out the heart rate. Some questions. What happens if you have 2 R waves? You just use the same R wave on each complex. So you either use the small R wave or the big R wave. As long as you're consistent, it's fine. If the heart rate is irregular, if the rhythm is irregular, good point, you then need to look over a bigger period of time. So look at, say, 10 beats, and then calculate the amount of time that 10 beats occur in, and then calculate the amount of beats that you'd therefore get in a minute, if that makes sense. And it doesn't matter which lead you use, as long as the rhythm is regular, you can use any lead. So ECG vectors, moving on. This is the confusing bit. So we have 6 precordial leads or chest leads, V1 to V6. V1, V2, V3, V4, V5, V6 goes in the axilla, okay, it goes in the armpit. It's just a bit difficult to show that on this diagram. You have a right arm lead, a left arm lead, a right leg lead, and a left leg lead. Okay, the way to remember which lead goes where is they're color coded. So right arm is always red, left arm is always yellow, left leg is always green, and the right leg is always black. And the way to remember that is ride your green bike. Okay, ride for red, your for yellow, and then green for green, and then bike for black. Okay, so ride your green bike. That's the way I remember it. And again, you're going to be tested on ECG lead placement in OSCEs. So something you need to know inside out. But I mean, I'm sure you all know that. You don't need to tell me how to put ECG leads on. This is what I want to get onto. The actual vectors themselves. Remember I said the ECG electrodes measure flow of positive charge, i.e. depolarization. If the depolarizing wave is flowing towards the electrode, you'll get a positive spike. If it's flowing away from the electrode, you'll get a negative spike. V1 to V6 all measure the flow of current in the anterior posterior plane, okay, or the axial plane. And you can see V1 coming out of the screen, V2 coming out of the screen, V3 coming out of the screen, etc. AVR, AVL, lead 1, lead 2, AVF, and lead 3 all measure current flowing in the coronal plane. So as you can see, AVL and lead 1 look at current flowing towards the left, AVR and lead 3 look at current flowing towards the right, and AVF and lead 2 look at current flowing sort of downwards. And these vectors are really important to become familiar with, because this is what's going to allow you to interpret an ECG. And this is what explains why we have 12 leads. Okay, so going back to the first question I asked you, remember, you have 10 electrodes, but you have 12 leads on an ECG. Why is that the case? Well, V1, V2, V3, V4, V5, V6, that all makes sense, okay? All of those electrodes simply measure current flowing or positive charge flowing towards or away from them. The current flowing towards the left arm is represented by AVL. The current flowing towards the right arm is represented by AVR, and the current flowing towards the left leg is represented by AVF. Okay, so AVL, AVR, AVF all correspond to current flowing between the left arm, right arm, and left leg. And then we have lead 1, lead 2, and lead 3. So lead 1 measures current flowing from the right arm to the left arm. Lead 2 measures current flowing from the right arm to the left leg. And lead 3 measures current flowing from the left arm to the left leg. Do you need to remember this? No. What you do need to remember is this diagram here. This is really important. I mean, who really cares where, you know, if it's measuring current from the right arm to the left arm? That's not so important. What you do need to know are the vectors and these angles, because this is super important. So my question is, now I'm going to show you why this is important. If I have an ECG abnormality in AVL 1, V6, and V5, what part of the heart is affected? So these leads here, AVL 1, V5, V6, lateral, exactly, because these leads all measure the flow of current laterally in the heart. So if you have a defect in these leads, that suggests the problem lies in the lateral part of the heart. If I have V1, V2, V3, V4 affected, where does the problem lie? So we've got septal, inferior, anterior. So it's, yeah, anterior septal, kind of the same thing. It's not inferior. These leads are not pointing downwards. They're pointing out of the screen, okay? They're pointing anteriorly. V1 to V4 measures the flow of current anteriorly. So if you have a defect in these leads, that means the problem is in the anterior part of the heart. If I have a defect in 2, 3, and AVF, where does the problem lie? Inferior, good, because look, these leads are pointing downwards. So if there's a defect in these leads, that must mean the inferior part of the heart is affected. We don't really use AVR too much. So I hope that kind of shows you why these vectors are so important and so useful, and really important when it comes to MIs, which I'll talk about next webinar. So as we said, 1, AVL, 5, and 6 are lateral. V1 to V4 is anterior septal. 2, 3, AVF is inferior. And each of these different territories are supplied by different arteries. And it's really important to know this pattern. These slides will be available for you there at app.biomedicine.com, so feel free to just go download them. I think they're already on there, actually. I'll cover this in the next myocardial infarction webinar, because we're a bit short of time. So ECG vectors done. Okay, summary. The ECG looks at the flow of positive charge, and if it's flowing towards an electrode, you get an upward spike, and if it's flowing away from an electrode, you get a negative spike. Cardiac depolarization gives us the PQRST morphology. P is atrial depolarization. You then have a little pause at the atrioventricular node, which holds the current for a bit. You then have a QRS complex, which represents ventricular depolarization. And then the T wave is ventricular repolarization. That's just a single complex, a single wave. The ECG consists of 10 different electrodes, which give us 12 views of the heart. The 12 views of the heart, the 12 leads, sorry, give us 12 different views of the heart. And because they're all looking at the flow of current in different directions, that's why the QRS, the PQRST morphology looks slightly different in each lead, because each lead is measuring the flow of current in a different direction. It's looking at the heart in a different way, okay? V1 to V4 are looking at the heart anteriorly. V5, V6, 1 and AVL are looking at the heart laterally. 2, 3 AVF are looking at the heart inferiorly. So they're all looking at the flow of current in different directions, and that's why each lead looks slightly different. And that's something you just need to get your head around, and you need to look at enough ECGs, enough normal ECGs to recognize what's normal. And as I said, one tip that I gave you, T wave inversion in 1 and AVR is normal, just because of the direction of current flow. Okay, next question. Axis. This is another thing which really confused me as a medical student. What is a normal axis? Let me look through some of your questions. How has it been at hospital? It's been tough. It's been tough. And, you know, obviously it's a busy period for all of us, but it's our pleasure to be here, and happy that I managed to make it on time to teaching today. What does high yield mean? That just means condensed, concise information. Someone's asked a question about axis, which we're going to get onto shortly. I'll give you a few more seconds to answer that. Please don't answer in the chat if you can avoid it. That would be much appreciated. Good. Yeah, it's minus 30 to 90. I mean, to be honest, I'm surprised most of you got that, because I didn't know that as a medical student. I barely knew how to calculate the axis, to be honest. So minus 30 to 90 is a normal cardiac axis. What is the axis? It's the overall direction of depolarization, okay? The heart, in general, depolarizes from the sinoatrial node towards the apex. It's really annoying because my animations don't work on the PDF, but I had some nice animations here. Never mind. The flow of depolarization is from the sinoatrial node towards the apex of the heart, towards the left ventricle. So the axis of the heart is going to be towards the left, just because of this current flow. Axis is the overall direction of depolarization. The bulk of the heart is the left ventricle. Most of the current flows towards the left ventricle. So the normal axis is towards the left ventricle. And if we look at these vectors again, that's defined as minus 30 to 90. So anything in this sort of quadrant here is absolutely normal. If the axis lies in this region here, that is normal. Just to give you some definition of these angles, lead 1 is defined as 0 degrees. AVF is defined as 90 degrees. This bit here will be defined as minus 90. And then, so it goes round in a circle, basically. Sorry, this bit here is defined as 180. And then this bit up here is defined as minus 90. But the point is, do you need to know the angles? No, you don't need to know the angles. I've never in my life been asked what the axis of the heart is in degrees. you need to know how to roughly work it out. You don't need to know how to calculate the angle. So what you need to know is the normal cardiac axis lies towards the left in this quadrant here. And then you need to know what's abnormal. So left axis deviation and right axis deviation. Left axis deviation is anything which is more left of minus 30 degrees. So anything around here, okay, minus 30 to minus 90 in this quadrant. And right axis deviation is anything from 90 to 180. So anything in this quadrant here. So I hope that makes sense. So this is a normal ECG. The axis on this is normal. How do we know? Well, I'm going to give you the dummy's guide to calculating the cardiac axis. And this is what most people in A&E in the hospitals will use. It's the simplest method. You look at lead 1 and you look at lead AVF. Okay. So looking at lead 1, if we're just looking at lead 1, what direction is the current flowing in lead 1? Is the flow of positive charge towards lead 1 or away from lead 1? That's my question. It's towards, good, because the positive is a positive spike. I know you've got a bit of negative spike there, but the most of this is positive. So that means in lead 1, positive charge is flowing towards it, okay? AVF, it's a positive spike. So what does that mean? In which direction is the charge flowing with regards to the AVF electrode? Again, it's towards. So it's simple. So in lead 1, current is flowing towards lead 1. In lead AVF, the current is flowing towards AVF. So if you take an average of those two, you have some current flowing laterally and you have some current flowing inferiorly. The overall direction, if you take the average of those two vectors, is towards the apex of the heart. This is a normal cardiac axis. I hope that makes sense, because this is really important in how to calculate the cardiac axis. So the way you calculate the cardiac axis is you look at lead 1 and you look at lead AVF. And then from those two leads, you can figure out if the ECG axis is normal. So a normal ECG axis is if you have a positive wave, QRS wave in 1 and AVF. So we have a positive QRS in lead 1, we have a positive QRS in AVF. Therefore, this is a normal cardiac axis. If you don't understand the angles and you don't understand all of this stuff about vectors, just forget that and learn this. Positive QRS in lead 1 and AVF equals normal. Okay, so right axis deviation. So if we look at lead 1 and AVF again, so in lead 1, is the bulk of the positive QRS going up or down? So let's take it from first principles. It's going down, okay? So lead 1, it's a downward deflection. So if lead 1 is a downward deflection, is current flowing towards or away from lead 1? Away. And that's why we have this black spike away, this black arrow away from lead 1. Simple. Looking at AVF, forget this first complex, that's abnormal. Looking at the second complex and the third complex, it's a positive spike in AVF. Okay, positive spike in AVF, what direction is the current flowing? Towards or away from AVF? Simple, it's towards, okay? So current is flowing away from lead 1 and towards AVF. If we look at the vectors, the overall average of those two is towards the right and down, okay? And this is known as right axis deviation. So the overall flow of charge in the heart is towards the right. It's a negative QRS in 1 and a positive QRS in AVF. And here is the dummy's guide to working it out. If 1 and AVF are reaching towards each other, that is right axis deviation. Okay, reaching for right axis deviation. Reaching begins with R, right axis deviation begins with R, simple. So you can see they're both reaching towards each other. Someone's asked, could you use, you can also use lead 3 as well. There's a more complex method which uses lead 1, AVF, and lead 3. Just use this simple method. Trust me, it's absolutely fine. Okay, fine. So now we know what right axis deviation is, but what are the causes? You know, it's all great being able to work out the axis, but what's the point if you don't know the cause? Right ventricular hypertrophy. So if you think about it, if the right ventricle is enlarged, you have more heart muscle on the right, therefore you're going to have more electricity flowing towards the right of the heart, and that's going to shift your cardiac axis towards the right. If you have a lateral MI, that's an MI on this side, that side of the heart is going to be incapacitated, so the bulk of your electricity is no longer flowing to this lateral bit, but it's going to be flowing towards the right. That's going to cause right axis deviation. Lung disease causes right ventricular hypertrophy, okay? Lung disease causes pulmonary hypertension, which in turn causes right ventricular hypertrophy, and as we know, that causes right axis deviation. Wolff-Parkinson-White and left posterior fascicular block. I want to explain this one because it's quite cool. So I didn't say this earlier, but remember, electricity flows along the right and the left bundles. The left bundle is split up into the left anterior fascicle and the left posterior fascicle. If the posterior fascicle is blocked, how is the left side of the heart going to depolarize? It's a question for you. So the right heart depolarizes through the right bundle, the left heart depolarizes through the left posterior and left anterior fascicles. But if the left posterior fascicle is blocked, what's the only route? There's only one way, it's the left anterior fascicle, right? It's the only thing that's left that can depolarize the heart. So why does that cause a right axis deviation? Well, if you look at the flow of current, it's going to come from the sinoatrial node to the atrioventricular node. It's going to come along here. It can't go down the left posterior branch because that's blocked. So it's going to go along the left anterior branch and then come round towards the right side of the heart. So can you see the flow of current is going to go down the left anterior branch and then round in a rightward manner towards the apex. So the whole cardiac axis is shifted to the right. And that's why understanding these basic principles are so useful later on when we come to discuss pathology, because when I tell you left posterior fascicular block causes right axis deviation, you're now going to understand that and hopefully not be confused. I hope that makes sense. This is just the ECG overall. I'll quickly explain that again. The left heart depolarizes through the left bundle. If the left posterior fascicle is blocked, the only way that the left heart can depolarize is through the left anterior fascicle. That means current's going to come along here through the left anterior branch, down here, and then depolarize the left ventricle, coming through the wall towards the septum. So can you see this direction of current flow? That's a rightward flow of current, isn't it? Whereas normally the current would come over here and flow upwards and leftwards. But because this branch here is blocked, it's going to go along the left anterior branch and flow downwards and rightwards. So that shifts the cardiac axis towards the right. Left axis deviation. Okay. Hopefully we'll be done in the next sort of 15 minutes. Lead 1, is this positive or negative? It's positive. So is current flowing to or away from lead 1? Towards, yeah? It's positive. Remember the ECG, if the ECG spike is positive, that means current is flowing towards. AVF is negative, therefore current positive charge is flowing away from AVF. So we have charge flowing towards lead 1 and away from AVF, the overall vector is in this direction, and this is defined as left axis deviation. What's the dummies guide? Well, a negative QRS in AVF and a positive QRS in lead 1. The dummies guide is if 1 and AVF are leaving each other, that's left axis deviation. L for leaving, L for left axis deviation, okay? They are leaving each other. Whereas here, they are reaching each other. So that's right axis deviation. Reaching for right, leaving for left. Look at leads 1 and AVF, simple. Causes of left axis deviation, left ventricular hypertrophy. Of course, if the left side of your heart is enlarged and bulky, you're going to have more current flowing towards the left, and that shifts your cardiac axis leftwards. Inferior MI, because that's the reason for that is because part of inferior MI knocks off some of your right ventricle, and therefore that's going to shift more current flow towards the left. Left bundle branch block and left anterior fascicular block also cause left axis deviation, and Wolff-Parkinson-White syndrome. So why does left bundle branch block cause left axis deviation? This is your left bundle branch here, and that splits into your anterior and posterior divisions, as we explained. If your left bundle branch is incapacitated, how is your left ventricle going to depolarize? What is the only possible way that it can depolarize if your left bundle branch is knocked off? So left bundle branch block means that this left bundle here is incapacitated, and the conduction is slow. So the only other way it can depolarize is through the right. So what's going to happen here is you're going to have electricity coming down. It's going to go down the left bundle. It's blocked, so it won't get much further. You'll then have charge coming down the right bundle, depolarizing the right ventricle. But also, you'll have current flowing from the right bundle upwards towards the left ventricle, because that's the only way the left ventricle can depolarize. And because you have this extra flow of electricity from the right bundle moving leftwards, that causes a leftward shift in your cardiac axis. And this is what left axis deviation looks like. Remember, forget everything, forget angles, it's not important. I've never been asked an angle in my life with regards to the cardiac axis. Dummies guide to axis, look at leads 1 and AVF. Okay, lead 1 is pointing up, AVF is pointing down. They are leaving each other. Leaving, therefore, must be left. Simple. Don't make it complicated. All right. So now we've done the basics of ECG. Now we're actually looking at an ECG. What do we do? Step 1, heart rate. Well, we already know how to calculate that because we've done that. 300 divided by the number of large squares between RR interval. Next step, rhythm. So this is the 10 golden steps to ECG interpretation. 10 golden steps. Is it regular? If it's regular, perfect. If it's irregular, is it irregularly irregular, or is it regularly irregular? Irregularly irregular is basically atrial fibrillation. Regularly irregular, second degree heart block, sinus arrhythmia. Ectopic beats can cause either. Ectopic beats are those which do not originate from the sinoatrial node, and they're just spontaneous, come out of nowhere. And they can cause a regularly irregular pattern or irregularly irregular pattern. Again, don't worry about the pathology. I'm going to go through all of this in the pathology section in a few weeks. Looking at this strip here, is this regular or irregular? So it's irregular, yeah? Because look, this is about 3 boxes, this is about 3 boxes, this is about 3 boxes, but then what's happened here? This is about 5 boxes, then it goes back to 3 boxes, then 3 boxes, then 3 boxes, then it's wide again. So it's like, so it's normal, 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 wide, normal, 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 wide. So I would say this is regularly irregular. What if you're on A&E and you see this ECG? Are you worried or not worried? This is regularly irregular in a young patient. What's your diagnosis? The consultant is asking you. What are you going to say? Well, because you've attended this ECG webinar and you're very smart, you know that regularly irregular rhythms are one of these three. So you have a 1 in 3 chance. And so far, none of you have got it. It's sinus arrhythmia. What is sinus arrhythmia? So again, this is another thing I heard at medical school, and it was just like, I had no clue what it was. But basically, it's variation in heart rate, variation in rhythm based on a patient's breathing. Okay. So it's heart rate variation based on the patient's breathing. When a patient takes a breath in, I believe their heart rate increases, and when they expire, their heart rate decreases. But I might have got that the wrong way around. I'm pretty sure it is that way around. You typically see it in young people completely normal. Okay, it's due to vagal, the vagal nerve activity changes based on respiration, and that's why when you breathe in and out, your heart rate changes slightly, and that can give you these rhythm changes. The PR interval is constant here, yeah, and it's not prolonged. That's why it's not heart block. The PR interval is completely normal. That's a normal PR interval. I don't see any prolongation of the PR. I don't see any dropped beats. So that's why sinus arrhythmia is absolutely normal in everyone. Axis, I'm not going to dwell on this. We've gone, we've done axis to death now. Fine. So we've done heart rate, rhythm, axis. Step 4, look at the P waves. Someone's asked what an irregular pattern looks like. It's coming, don't worry. So look at the morphology, P mitrale or P pulmonale. P mitrale is a bifid P wave. P pulmonale is a peaked P wave. And this signifies right atrial enlargement, and P mitrale signifies left atrial enlargement. So important to know. Is the P wave absent? Okay, atrial fibrillation gives you absent P waves. Is it a sawtooth pattern that's seen in atrial flutter? Is the P wave dissociated from the QRS? Is there some abnormality in the PR interval? And that's seen in atrioventricular heart block. Okay. Another point of confusion. What's the difference between flutter and fibrillation? Okay, atrial fibrillation is irregularly irregular. I for irregularly, I for irregular. Okay, irregularly irregular. Don't forget that. Atrial flutter is regular. So that's the first difference. The second difference is no P waves in atrial fibrillation. In atrial flutter, you have this sawtooth pattern. Okay. You can see this sawtooth pattern here. That's classic of atrial flutter. They are both atrial arrhythmias. I'm not going to go into the pathology now. We'll cover that in our next webinar. I just want you to get a flavor of what you're looking at when you're looking at the P waves and the rhythm. So someone asked, what does an irregularly irregular pattern look like? This is irregularly irregular. You can see there's no, it's just completely all over the place. These are the sort of things you need to pick up. Yeah. Okay, so you've done the P wave. Next step, PR interval. Just take it. So at this point, you're just taking it in turns. P wave, PR interval, QRS wave, ST segment, T wave. Simple. The PR interval, if it's prolonged, heart block. If it's short, accessory pathways. Accessory pathways mean that, so normally you have charge flowing from the sinoatrial node to the atrioventricular node to the ventricles. An accessory pathway means there's a way of bypassing the atrioventricular node. Okay, so the atrioventricular node can in some way be bypassed and reach the ventricles quicker. And that's known as an accessory pathway. And the one that, and that will shorten your PR interval because electricity is reaching the ventricles quicker than it should, because normally the checkpoint is the AVN, and that holds the electricity there for a second. But if you have a route around that, obviously your PR interval will be shortened. PR interval is depressed in pericarditis. Okay, this is really important. They love to test this in exams. I don't know why. I've only seen it like twice, but it is a quite specific sign of pericarditis. Fine, we've done P wave, we've done PR interval. QRS, if it's widened, that suggests bundle branch block. Why is the QRS widened in bundle branch block? Well, allow me to explain, unless someone can explain it better than I can in the chat. But normally you have electricity coming down the right bundle and the left bundle and the different branches of the left bundle. But in bundle branch block, one of these bundles is impaired. So conduction along one bundle will be quick and conduction along the other bundle will be slow. That means overall ventricular depolarization is delayed. Okay, exactly. I knew someone would explain it better than I would. So Stephanie has said one side depolarizes quicker than the other. So basically, normally you have quick depolarization of both sides. But in bundle branch block, because one of the bundles is a bit blocked, one side depolarizes quickly and the other side depolarizes slowly, and that widens your QRS, because the QRS represents ventricular depolarization. And if ventricular depolarization is delayed, then the QRS is widened. In any tachycardia, the first thing you need to do is assess, is the QRS narrow or is it broad? Because this will tell you what type of tachycardia it is. A narrow QRS complex means the tachycardia is arising from above the ventricles, i.e. supraventricular. One of the most common being atrial fibrillation, which arises from the atria. If the QRS is broad, i.e. longer than, typically we say 120 milliseconds, then that means the arrhythmia is arising from the ventricles. The other thing you want to look at is the amplitude. If the amplitude is increased, that's suggestive of ventricular hypertrophy. Because obviously if you have more muscle contracting and depolarizing, the size of the QRS complex will be greater. Okay. So what's this rhythm down here? So these are both tachycardias. This is a narrow complex tachycardia, and this is a broad complex tachycardia. So this is a supraventricular tachycardia, and this is a ventricular tachycardia. VT, dangerous. VT is bad. Patients in VT, they could die imminently or cardiac arrest imminently. So if as an F1 or even as a medical student, you see a patient with this ECG, you call for help straight away, okay? Because this is potentially fatal. Someone's asked what V1 versus V6 is. Depending on the distribution of the large amplitude QRS complexes, you can tell whether it's left ventricular hypertrophy or right ventricular hypertrophy. I've actually forgotten which is which, so someone will probably say in the chat, but large QRS complexes more towards V1, V2 suggest one side is hypertrophied, and large complexes more towards V5, V6 suggest the other side is hypertrophied. I just can't remember which way around it is, so apologies for that. If someone knows in the chat, just let us know. Okay, last 5 minutes, I promise. So you've done the QRS. The next thing is to look at the QT interval. So that's this interval here, QT, yeah? The time taken between ventricular depolarization and repolarization. Love to test this in exams. Again, I don't know why. Actually, no, it is quite important. It is quite important. A lot of, why is a prolonged QT worrying? What's the thing? What's the one thing that it can, really dangerous that it could cause? Not MI. It can cause sudden death, but why? What rhythm can it deteriorate into? Yeah. So someone has said it, a few people said it in the chat, torsade de pointe. Have a look in the chat if you want to know how that's spelled. It's basically a ventricular arrhythmia. Prolongation of the QT can deteriorate into a ventricular arrhythmia. QTC should not be any longer than this. In men and women, it's slightly different. If it's prolonged beyond that, there's a risk of it deteriorating into a ventricular arrhythmia known as torsade de pointe, which looks a bit like ventricular tachycardia, actually. The reason that's bad news is because patients with that can cardiac arrest. What are things which cause a prolongation of your QT interval? Drugs. Learn this list. You will be tested on it. Macrolides, tricyclics, antihistamine, haloperidol. There are others that I haven't put on here, like ondansetron, for example. But you can memorize probably 100 drugs which cause a prolongation of your QT. Just learn these high yield ones. Inherited defects in ion channels in the heart, known as long QT syndrome, and there are various subsets of this, which we will go into in the pathology lecture. Myocardial infarction, low levels of electrolytes, low potassium, low calcium, low magnesium, all prolong the QT interval. So if you look at this here, this is normal. The QT is approximately how many? 1.5 boxes. Okay, the QT interval here is approximately 1.5 boxes. That's normal. The QT interval here, as you can see, is actually massive. It's 1, 2, almost pretty much 3 boxes. The QT interval there spans 3 boxes. The QT interval here spans 1.5 boxes. So it's important you know how to calculate that. Fine, we've done the QT. Next step. The QT is corrected, by the way. I'm not going to explain that. If you're interested, I can stick around at the end and explain that. ST segment is the next thing you look at. We've gone over it. The most important thing, ST segment thing to look at is for an MI. This shows ST elevation. Can you see the ST segment is elevated? It should not look like that. And it's elevated in some leads and it's depressed in other leads. This is classic of a STEMI. You have ST elevation in some leads and ST depression in other leads. Classic of a STEMI. And again, I'm going to go over that in my next lecture. But important to look out for. Then you look at the T waves. It's inverted in ischemia and MI. But remember, it can be normal in AVR and V1. It's peaked in hyperkalemia, means it's pointy, and it's flat in hypokalemia. They love to test potassium changes on ECG in medical exams. Have a look through these slides, have a look at our textbook. It's all there. We have a whole section on hyperkalemia and all these ECG changes. So do have a look. Then other stuff, U waves, J waves, delta waves. U waves, hypokalemia, J waves, hypothermia, delta waves, Wolff-Parkinson-White syndrome. Okay, you can go look these up and see what they look like. But a U wave is essentially an extra wave after the T wave. A J wave I will show you shortly, and a delta wave I'll show you in the next lecture. What's gone on here? Diagnosis in one word. Good, hyperkalemia. The T waves are peaked. Look how big these T waves are. They're massive. Look at the one in V3. It's huge. It's bigger than the QRS complex. This is actually quite a good ECG. T waves are far too big. And that peaking of the T wave suggests hyperkalemia. You look at every lead. Okay, but you can see it's actually peaked in a lot of the leads. So it's peaked in 1, 2. You can say AVF looks a bit peaky as well. It's peaked in AVR, V1, V2, V3. It's pretty much peaked in every lead. So you can say that's definitely hyperkalemia. This is a J wave, also known as an Osborne wave. Okay, it happens just after the QRS complex, and you get an extra little spike. And it's classic of hypothermia. Again, another pointless thing that medical school exams will test you on, but you'll never probably see in real life. But there you go, just learn it. You have to be very hypothermic to develop J waves. We're talking around 31, 32 degrees, you know, very hypothermic. Someone's asked a good question, actually, that I want to touch on. What's the rhythm strip? The rhythm strip is lead 2. Okay, lead 2 and the rhythm strip are the same. So this is the rhythm strip down here, and it's just the same as lead 2. Lead 2 is used to assess the rhythm the best because it gives you the best morphology of the P wave. Okay, which of the following is a diagnosis based on the ECG shown? Okay, let's go over to the next question. Final 2 or 3 slides, I promise, and then we're done. So what's the diagnosis based on this ECG? Just stick around, please, because I'm going to go over our upcoming webinars and show you what's in store. And it's really important because it all ties into this. If Azim's still around, please post the feedback form whenever you get a chance. So which of the following is a diagnosis based on the ECG? Shown. Lateral end STEMI, lateral STEMI, inferior end STEMI, inferior STEMI, anterior STEMI. And remember, before you all head off, we have a discount with GKT MSA, 30% discount on our monthly subscription. And the code I'm going to post in the chat. Code is GKT 2021. That'll give you 30% off all of our resources, textbook, webinars, you name it. So please do check it out. Inferior STEMI, good. So remember, it's all to do with the leads. Where is the ST elevation? 2, 3, AVF. Because you're all vector masters by now, you know 2, 3, AVF is the inferior part of the heart. Okay, recap. Final 2 slides. Flow of positive charge causes positive spike on an ECG. PQRST morphology, know it inside out. 10 ECG leads produce 12 vectors. Okay, these are 12 different views through the heart, and that's why each lead looks a bit different. The different vectors of views allow us to localize pathology. Follow my 10 golden steps to interpreting an ECG, and you will do well in life. Feedback form is in the chat. Discount code is in the chat. The discount code is open for everyone, okay? If you've come to this webinar, check out our resources. A bunch of them are free. And there's a 30% discount code in the chat as well, which gives you access to our comprehensive textbook, our novel multi-step SBAs, and all of our webinars, okay, all of them. Here's what we're going to cover in the upcoming webinars. I'm going to go over acute coronary syndrome, and that's on the 18th of February. And my colleague Richard is going to go over all of these pathologies in his ECG webinar with GKT MSA, and that's in March. So we're going to go over all of your arrhythmias, your heart blocks, your potassium, problems, Wolff-Parkinson-White, Brugada, all of it, you name it. But please do check, in the meantime, tune into Azim's webinar on ECG interpretation in 5 days, and his fluids webinar in 2 weeks or so. They're going to be brilliant. We've got lots of interest in these webinars. I think is it something like 1,000 people interested on the Facebook group. In fact, 8,000 people interested on the Facebook group. So, don't be the person that misses out. It's free. You don't lose anything. And Azim's a much better teacher than I am. Check out the feedback form. Please fill it in. Azim's posted it in the chat. It means a lot to me. And yeah, thank you so much for bearing with us. I've just finished a long shift, and but I'm glad I could make it to this teaching and impart my ECG knowledge. I'll stick around for a few minutes. I'll stick around for a few minutes for questions about whatever you want to ask, really. Joe Waters says, thank you so much, we'll be getting subscription. Joe, thank you. Just looking through some of your questions in the chat. Why is PSC more common in ulcerative colitis compared to Crohn's? I don't actually know. I will research that one and maybe get back to you. Do we have to look at lead 1 and AVF? Or would lead 1 and lead 3 be okay? I assume you mean for the cardiac axis. Just look at 1 and AVF is the simplest thing. I don't think there are many more questions, really. I mean, you're welcome to ask questions. Could you explain the corrected Q? Oh, yeah, sorry, the corrected QT. So the problem is your QT is going to vary based on your heart rate, right? Because obviously the faster your heart's beating, that's going to impact your QT. So what the QTC is, the corrected QT interval, is it corrects the QT interval and standardizes it for a heart rate of 60. So that means if I have a patient who has a heart rate of 100 and I have a patient who has a heart rate of 40, the ECG machine does some magic maths, which then standardizes those QT intervals for a heart rate of 60. So it tells me the QT interval in the patient with a heart rate of 100, what their QT interval would be if their heart rate was 60. And it tells me for the patient with a heart rate of 40, what their QT interval would be if their heart rate was 60. So it just standardizes the QT interval for a heart rate of 60. Oh, wow. So it seems there's 9,000 students interested or attending or interested in the ABG interpretation. Very impressive. The slides will be uploaded. The webinar recording, providing this all works, will be uploaded. Okay, so I'm going to tune out. Remember, GKT 2021 will get you a 30% discount on all of our resources. And try it for the first month. If you don't like it, you can unsubscribe. And there's a bunch of free stuff on there if you don't want to pay any money. If you have any questions, you can drop me an email. My biomedicine email, shoaib@biomedicine.com. And please do tune into our subsequent webinars, which are coming up. But yeah, okie dokie. I bid you all adieu.